Hello everyone. I'm Dr. Murtaza. So this is a practice session which is open for all. And I have three stations today. One is a communication, one is a video, and one is a clinical station. It's a mixed bag. So any of you, any one of you, like three of you can volunteer to practice this. Okay. So first we'll start with the communication station. So one thing which is important, which I always emphasize for all my students, is that they should be knowing the exact timing for any clinical, for any station in MRCPCH. There are total of like 4 minutes when you are sitting outside the clinical station or any other station, and there will be for communication you will be inside for 9 minutes, which will be divided into 6 plus 3 minutes. After the 6 minutes you will have a bell, and then there will be 3 minutes remaining. Okay. And for any station, is it is very important for you all to know how you are marked, because then only you will try to cover the maximum parts in that. Because if you do not cover a particular part, you won't be marked in that station, which is something not good. So in a communication station which is of 8 marks, for your information sharing and accuracy of that shared information, you have 2 marks out of 8. The way you communicate, the communication style and the rapport which you make fetches you another 2 marks. Your listening skills and verbal skills will fetch you another 2 marks, and managing of the concern which the role player asks you fetches you another 2 marks. So these are some of the important things which you have to keep in mind while practicing and even during the examination, so that you are able to get marks in all of these. Then only you will be getting 8 out of 8 in the communication stations. And communication is something which needs to be practiced. So it is advisable that you practice at least the communication stations at least two daily for those who are going to appear for their clinical examinations, which is very much important. So these are some of the scenarios which are normally used in communication station. The most important thing in communication is whatever background knowledge you have about the thing, you should be always be ready to answer the queries which the role player have. You should not have what you have read and going to the examination in mind, and you are trying to address it. Try to answer the role players like what his queries or her queries are. That is very important. And I would recommend that the patient information leaflets, which are from NHS, are very much useful for these communication stations. So try to read them. They are it hardly takes 5 to 10 minutes for each of the communication scenario to be read, and then it is a very useful because they have given it in the patient friendly manner without any jargons and all. So without wasting much time in theory, I would like any one of you who wants to practice a station of communication can volunteer, and then we can start. I have three total, so one of you can
I
volunteer
can
for
do
topic.
practice.
What's your name, doctor?
Iram.
Dr. Iram. Okay. So you want to do that. Okay. I need one of who wants to do the next one, a clinical station, and who wants to do the third one, because I'll use them as timekeepers. Who wants to do
Sir,
the video?
sir, I want to do clinical, sir.
Okay.
Reshma.
Dr. Reshma for clinical. Okay. Dr. Iram for communication. And who wants to do the video? Any one of you? No one. Okay. Then I'll pick
I
up.
can do video if no one available.
We'll see. We'll see by that time. Not an
Okay.
issue.
Yes. If no one,
Okay.
so
Done, done, done. So we'll start with Dr. Iram. Dr. Reshma, you'll put the timer for Dr. Iram.
Yeah,
So,
yes, sir.
so 4 minutes will be there to see the scenario, Dr. Iram, for you. Okay, you
yes,
can
yes.
see the scenario for 4 minutes, and once the bell goes, you have 6 plus 3 minutes, in which you will be given a bell at the end of 6 minutes and then at the end of 9 minutes. So you can start the timer, and this is your scenario. You have 4 minutes.
Yeah,
Okay,
time
sir.
started.
Yeah.
Time finished.
Okay, you can start.
Okay. Okay. So good morning.
Good morning.
I am Iram, one of the doctor here. I believe I am talking to Yusuf, working in this department.
Yeah, yeah, doctor. I know you well.
Okay. Yes, I saw you in the ward working enthusiastically. So, how's the rotation is going on in the ward?
Yeah, it's going on perfect, doctor. Like I'm seeing a lot of patients, and I am really like impressed the way you people are managing the small kids. They come in such critical conditions, and like it's really I'm enjoying my posting here, doctor.
Thank you so much for the feedback. And I hope as you are working, you are enjoying with us. So in future, you will do work here. And I admire your way of amazing job. So hopefully best for the you in the
Thank
future.
you. Thank you, doctor.
Okay. So Yusuf, I come to know that you have some concern about the insulin and its type.
Yeah,
So
yeah,
today I
yeah.
make arrangement.
Right, right. Okay.
Okay, so if you want any of your colleague to attend this session, it's most welcome.
Yeah, actually, all of them are busy in their like rotations. So I'm there.
Mm-hmm.
We can maybe discuss some part of it so that it becomes easy for me to understand these, doctor.
Yes, it's most welcome. Okay, so can you please tell me how much you know so far about insulin and what are the type of insulin?
Yeah, yeah, doctor. Actually, what that I remember this child, this 7-year-old child, Jack, who is now
Mm-hmm.
in like he came in DK 2 days back, and you people managed
Mm-hmm.
him so well. Now he's being planned for like for discharge, and you have started on some like now on subcutaneous insulins. So I'm really not like confused about the different types of insulin. Like I know the names of some of them, like regular, glargine, and all, but how to use them, what are they, how long do they act, when to give them, and there are different regimens also, I suppose. So actually I'm a bit confused like what these are, so I wanted to discuss it before I can go and read about it, doctor.
Okay, thank you so much for sharing this background knowledge. So before move to the insulin and their types, as you told me in detail, whatever you know. So do you have any idea what is insulin dependent diabetic mellitus?
Yeah, insulin dependent diabetic mellitus, normally I understand that there is like there is some issues in the like insulin cells are not being produced like
Mm-hmm.
by the beta cells of Langerhans, right, doctor? And
Yes,
due to this,
yes,
and
yes.
it normally involves like mostly in the kids, most of the cases.
Yes, thank you so much. So in this case, when there is a lack of insulin or deficiency of insulin in the body, so we have to give insulin from the outside. For that reason, we are calling this insulin dependent diabetic mellitus. Am I
Yeah,
clear so far?
yeah, doctor. You're making
Okay,
yourself clear to
okay.
me.
So in this case, when we are giving the insulin from the outside, so actually what happened that whenever we are eating food,
Mm-hmm.
so body produce insulin.
Right, the
Okay.
normal physiological process, right, doctor? Yeah, yeah.
Yes. Okay. And on that time, there is surge of insulin. Otherwise, we have baseline insulin level in our blood. We have
Okay.
baseline insulin level at the blood, but whenever we are eating food on that time, there is extra insulin produced for that food. That is called our normal physiologic phenomena. Am I clear so far?
Yeah, yeah, I'm getting you, doctor.
Okay. So, what's the function of insulin? Can you please tell me?
Yeah, the insulin basically, the more glucose in our body, it will convert the glucose and keep it for storage in other forms,
Mm-hmm.
doctor. This is what I know. It will decrease the blood
Okay.
sugar and
Okay.
convert it into like storage forms.
Mm-hmm. And what it will body will do for this when, because I will tell you in detail,
Mm-hmm.
whatever you told, it is okay, good. What is insulin doing? It is acting on the cell to open the door. So in this case, the glucose that is in the blood, it will go inside the cell and the
Mm-hmm.
body can use it.
Mm-hmm.
Okay.
Yeah. Okay, doctor.
Otherwise, glucose will remain in the blood and it will not go inside. Like in this child, this case happened that there was very high level of the glucose And then what happened? It was not going inside. Body was not able to use as a fuel. Are you following me?
Yeah, yeah, I got it. Like insulin basically opens the like channels for the glucose to enter inside the cells, right, doctor?
Yes, yes.
Right. Okay.
So what we are doing, we are giving the child the insulin. This is called the basal bolus regime.
Mm-hmm.
Okay, in this condition, we are giving the long acting insulin as you give me before that some kind of the insulin. So, do you have any idea that long acting insulin, how much time it can work?
Yeah, like what I know is long-acting insulin normally they work like they do not have any peak and normally they will be working throughout the day, doctor.
Yes, very good. So, it will maintain the baseline. Okay, and
Yeah.
then for the every food, we will give the short acting insulin.
Oh, so many pricks you mean, right, doctor?
Yes, unfortunately, it is like this, but it is
Mm-hmm.
not for the always. Because when the blood sugar level will be controlled and everything will be okay, so on that time the endocrinologist might change the regime.
Okay, okay. From this basal bolus regimen of multiple pricks to something lesser, right?
Yes,
You mean, doctor? Okay,
yes,
okay. I
yes.
got it, doctor.
Okay,
Sir,
so you got the idea of what is the basal bolus regimen.
Yeah, I got it. Yeah, I got it, doctor.
Mm-hmm.
Mhm.
Okay, okay, okay.
sir, last
So
trick.
okay,
Okay.
so do you have any other questions so I can move further?
No, for I understood your basal bolus regimen. What are the other regimens like and like how are they decided? Like what do they use in that?
Yes, like as you discussed, there are multiple prick and so many things. So we have something new that is called the artificial pancreas. So in
Mhm.
this, there is a pump that we will attach to the body,
Okay.
and this will provide 24-hour checking and provide insulin according to the need of the body. This is the
Oh,
new
great.
technology.
Like it's more like more physiological than injecting the chest
Yes,
multiple times. Oh, great.
yes,
That's
yes,
great.
yes.
Okay.
So do you ever heard before this
I have
that
heard
insulin
something
pump?
like, yeah, I have heard about insulin pump, but I was not very sure of like how does it work and it monitors continuous glucose. That is something like quite great, I think, doctor. Yeah.
Yes, actually, it will monitor by itself and it will deliver the insulin according to the need of the body, and it is very convenient for the children.
Mm-hmm. I'm getting you, doctor.
Okay.
Right. Okay.
Okay, thank you so much. So, but we have to tell to the child about and the parents, so especially about the sign of low glucose. That is, if the child is feeling hungry and dizzy, so they have to check blood glucose and give some sugary food
Oh,
because
yeah, the
sometimes
signs
what
of
happen? Yes,
correct. Got it. You are telling
kind
about
of
the signs of
hypoglycemia.
hypoglycemia. Right, right, doctor. Yeah,
Yes.
correct. Okay.
And on the other hand we have to tell them from for the sign of hyperglycemia also, like if child is suppose eating too much sugary food, and so in that case they have to check and take if child has fever or some other condition, so they have to contact to the doctor.
Mm-hmm. Like
Am I
something
clear
like
so
the
far?
yeah, something
Mm-hmm.
like the sick day rules you are telling, right, doctor?
Yes, yes,
Yeah, yeah,
yes.
yeah. Yeah, I have heard about that also,
Okay.
doctor. You made the things easy
So
for me, doctor. Yeah.
yes, and with this, we have to tell to the parents about exercise, increase fluid intake, and balanced diet.
Yeah, yeah.
Are we on the
I
same
agree
page?
with you. I agree with you.
Okay.
Right.
So, do you have any other question?
As of now, you have made the things like quite easy for me. Like the platform is made, I can go through it now through my textbook. Yeah.
Yes, it's very good, and I will give you some leaflet and some website. You can go through this, and we can arrange one more meeting if some question you have. And what about if you arrange one seminar on the type of insulin or diabetic ketoacidosis?
Yeah,
So
great idea. But
other fellow,
yeah, I got it. That will be a great idea, doctor. But you will have to help me out in that seminar.
of course, it will be my very pleasure for me to help a keen student like you, and it will be honor for me, and I will help you whatever you whenever you need it. Is that okay with you?
Yeah, 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 doctor. Thanks a lot for your help and time, doctor.
Thank you so much, and wish you on the highest post very soon.
Okay. Thank you,
Thank you so
doctor.
much for your time.
Thank you, doctor. How much time is left? Still time
Time
is left.
I
finished.
think I finished. I
Time,
think.
Oh, time finished. I
time.
didn't hear the last one. So, what are your feedbacks? We can start with you only, Dr. Iram. What is your feedback about your performance now in this case?
Uh, yes. Actually, it was the different type of the insulin and their regimen, and I know actually basal bolus regime in this child. So I go through this,
Mm-hmm. Okay.
and I
So
do know.
see, yeah, I got your point. I got your point. So you might be not be knowing all the regimens. That's okay. Many times in communication station, there will be things like we might not be knowing about it. So you can always tell
Yes,
that, okay, I know about this regimen. There are other regimens
yes.
which I also will have to go through it and then we'll discuss about it. That will be better. That you have to be clear about that. That's okay. What I
Yes.
recommend you in this is try to make some diagram because in
Mm-hmm.
communication station when you are sitting outside 4 minutes you have ample time. So what you have to do in those 4 minutes, first write clearly the name of the role player. If there is a
Yes.
child and there is a mother, something like that, write the name of the child bigger because you should not be confusing the child's name with the mother's name or the father's name. In this case, there was no
Okay.
child's name, only the name of the doctor, so that's okay. But what I recommend is
Yusuf. Yes.
always put the name of the child in above part and the age clearly male or female. You should not be saying him to her or her to him. It puts a bad impression. It will fetch you less marks. So don't say him,
Mm-hmm.
he or she the other way. Okay, him or her. That's very wrong. Second thing, do not confuse the name of the child with the role player or who is the mother or the father. Never to be confused. It again will cut your marks. That is for sure. Okay, these things are, and you should be addressing the child if there is a child's name by his name rather than telling your baby or my baby, something like this. Try to put the child's name. In this case, there is no child's name, but in other scenarios for communication. Okay, okay. Then, what I prefer in this case, always try to make some diagram because you talked about basal bolus regimen. That
Yes.
was
Yes. Yes.
quite good. Try to put some
Mhm.
diagram which will make the
Yes.
things
I
easier for
made
you.
on my paper, but I
Okay.
was not able to show. So
Okay, that's okay. That's
yes. Yes.
at least you should mention. You okay? You can see
Yes.
my photo like this. Okay, that's good.
I
So you can
I
just tell.
got.
Yeah, yeah. So that will be there. If you don't know the other regiments, you can frankly tell that okay, I know about this. Other things I'll get down. Of course, there are other regiments which will be like maybe less physiological but lesser number of pricks, things like that. But I'm really frank. Frankly speaking, I'm not very sure of them. So let me also study and get back to you again. So that will be a frank answer and which will not cut
Yes.
your marks. Okay. It was good that you did not tell anything which was wrong. You confined yourself to the points like to information giving which was correct and accurate. That was good. Okay. The second important point, which is to be like I'm telling general, I'm not commenting on you. The second point is like in the case of communication, what you have to do, let the role player speak more. So you were giving in your station, you were giving time, you were asking the role player about, okay, you must have heard about it. What do you know? Because he is a junior of him, he is a first year ST1. So he is a registrar there, right? So he also knows about this. So it was good that you were asking him. Okay, and he was explaining the things many a times he came out, okay, it looks like more physiological and those things, so he's knowing, so that background knowledge will be helping you in rolling your communication. So a general rule for any communication station is you have to speak less, let the role player speak more. That is very important. Okay, and your verbal and listening communication skills will be assessed in that part only. Many a times I was interrupting you when you were speaking, that can also be there, that was intentional, but you won't be demarked for it because you were not interrupting me, the role player was interrupting you. Okay, it can be there many times that the player is a voracious like history giver or something like that. He likes to talk, so it can be there, but you were like listening to what I wanted to say, so that was good. That will fetch you your listening and verbal communication skill. That was good, and you were able to manage the concerns which the role player wanted. He wanted you to discuss about the different, he was confused about the different regiments and all. And your task was on that only, that you have to discuss about the different like insulin types and regimens. So
Yes.
types part you did not cover at all different. Like you went directly into the regimens. type part you should have at least told that he told that he knows about short acting and long acting. You can also tell that, okay, in addition to what you know of, there is something known as rapid acting or intermediate acting also. So there are four types. He knows
Yes,
two
yes,
of them. So just because
yes.
the task was to like he was confused about the different types and regimens. So
Mm-hmm.
both were to be covered. You asked him, he told about two types. He knows about the long type, he knows about something known as the short acting. But he wasn't aware of something known as the rapid acting or the intermediate acting. So you can tell, कि, okay, you know two, there are two more, okay, this way. With appreciation.
Yes,
You
I
are
got.
appreciating it well. That was good. So just try to complete that because the task will be always like assessed. What task you have
Mm-hmm.
been given, na, that will be always assessed. So you have your task was different types of insulin and regimen. Okay. So that part was to be covered. So overall, when you started like with your colleague, he's your junior colleague. So you can start with him in a less formal fashion. Okay, na? So you can start, okay, okay, you must be knowing me this way. Like, good morning, you know that matlab, you must be knowing me, right? Rather than telling yourself your name, because he is
Mm-hmm.
your junior, he must be knowing. Then he will tell, yes, yes, doctor, I know you very well that way. Okay, now in this case, you
Yes.
might not tell your name also, you won't be demarked in this because you both are working in the same ward. He is ST1,
Same. Yes.
you are ST3. So you can be
Mm-hmm.
less formal in this case. It was good that you summarize the things in the last rather than giving leaflets to your junior. Okay, now you would recommend him some like papers, publications, and books.
Okay.
Okay. Websites
Mm-hmm.
can be given, but rather than giving leaflets, leaflets are normally given to the patients. So don't give him leaflets. You can give him some papers, good papers or articles. You can give him textbooks. Tell him the textbooks where to read from. That can be given rather
Yes.
than telling him leaflets. Okay. It wasn't wrong, but it looks a bit odd. Like leaflets, we won't give to our juniors, right? Those are meant basically for the patients. So
Patient.
try to tell
Okay.
them. It was good that you came up out with seminar and then he came out, okay, you will be helping. So overall, you tried to cover all the parts and the parts which were not sure, you did not commit on it. That was good. Okay. So just try to go through this insulin regimens. They will be asking about it. These all are given
Yes.
here in your Reham notes. You can go through it. It's directly from there.
Okay.
Okay. So this is the
Mm-hmm.
twice daily regimen, which is known as Mixtard. So that way it goes. And insulin pump you told
Okay.
about that was good. So overall it was good. Good. Nice attempt.
Thank you. Thank
Okay.
you so much.
Without wasting time, we'll move on to the second station. I think Dr. Reshma wanted to do the clinical one. So we'll
Yeah,
give Dr. Reshma. And we have the third one. Any one of you who wants to do the video station after Dr. Reshma? Any volunteers? If we do not have, we have to give it again to the first presenter because she volunteered for it. If someone as of now wants to present the third station video, any volunteers for the video station?
Can I
I
try,
can do,
sir?
sir.
Dr.
Okay.
Shajita. Okay. Okay, you can try, not an issue. We can use. So Dr. Shajita, you will put the timer for Dr. Reshma then for her
Okay.
clinical case. Okay.
Okay, sir.
So for clinical, we'll be directly like starting from here. You won't have anything outside. You will be just sitting. You don't know what is lying inside in the clinical station. So maybe you can start the timer for her. So you can start the timer. This is 6 plus
Yes, sir.
3, and you have to examine the CVS of this 10-year-old Samuel.
Okay, sir. Can I start?
Yeah, you start. The time has started. Yeah.
Okay. So I'm entering the exam hall, hand over my mark sheet and wishing the examiner. Hello, sir. I'm one of the candidate, Dr. Reshma.
Yeah. Good morning, doctor. You have to examine the CVS of this 10-year-old Samuel.
Okay. So after hand washing, any bystander is there with Samuel?
His father is there standing with him.
Yeah. So I'm introducing him. Hi, I'm Dr. Reshma, one of the child doctor working in this hospital. Can I check Samuel heart today? Is it okay for you?
Yeah, yeah, sure, doctor.
Okay. Hello, Samuel. How are you?
Hello, doctor. I'm fine, thank you.
Okay, okay, Samuel. So today I'm going to check you, check your heart. So in between, if you feel any discomfort, let me know. I'll stop. Okay,
Sure, sure, doctor.
okay. So I'm checking any devices.
No devices attached.
He's in any distress.
He is not distressed.
What about his height, weight?
He looks thin, height looks okay.
Okay, so I would like to plot at the end.
Okay.
And any dysmorphism?
He is not dysmorphic.
Okay, so I'm starting from his upper arms. Any clubbing? Okay,
Yeah,
I
you have checked for the
will.
clubbing, so clubbing is present.
So I will ask him, can you approximate, yeah, can you do like this? Okay, I can
Okay.
see the topic, and I'm checking for any signs of infective endocarditis, anything.
No signs of inverted endocarditis in the hand.
Okay, I can see the cyanosis also. I'm checking the pulse both sides for 1 to 6 seconds. Okay, Samuel, I'm checking his axilla. Can you put your arms on your
Barabar,
head?
barabar. Yeah, he
Hello.
is putting his axilla. So there are a fine few hairs are there.
Okay.
Thin hair.
Then I'm showing the pallor. Can you do like this to lower the palpebral conjunctiva?
Okay, he is doing it. No pallor. He looks the conjunctiva looks to be suffused.
Okay. And then I'm checking the oral cavity for the oral hygiene. What about the oral hygiene? Okay, I can
Oral
see the.
hygiene is okay, normal.
Okay. Then I can see the central cyanosis. Yeah. Then I'm checking the neck. Any pulsations? Any neck pulsations?
No neck pulsations.
Okay. Samuel, can I remove your shirt? Can I have a look at on your chest? Is it okay for you?
Yeah, sure, doctor. He has removed his
Okay.
shirt.
Okay. On inspection, I'm inspecting from the side and the foot end. Yeah, I can see a central sternotomy scar and a lateral thoracotomy scar also. And I'm warming up my hand. Then I am palpating the apex beat. Where I am getting the apex beat.
Apex beat is in the left intercostal space, fifth intercostal space, just 1 centimeter medial to the midclavicular line.
Okay. Any parasternal heave.
No parasternal heave.
Okay, then I am palpating all the four areas like aortic, pulmonary, and left level sternal border and mitral area. Any palpable pulsations
No
or any
palpable
thrill?
pulsations. No thrills.
Okay, then I am checking with my stethoscope all areas. What about the heart sounds?
The heart sounds are like first heart sound is normal. Second heart sounds looks to be single. No third heart sound. No fourth heart sound.
Okay, so any murmur?
No murmur heard. Where are you palpating for the murmur?
I'm auscultating
Auscultating.
the aortic area, pulmonary area, left lower sternal border, and mitral area.
No, no murmur at all in these four areas.
Okay, no murmur, a single second heart sound.
Mm.
Okay, then I'm palpating, I'm auscultating the carotid and carotid area and axillary area. Any murmur?
No murmur.
Okay, I'm checking the back also. Any findings? Any basal crusts or anything?
No basal crypts. No murmurs.
Okay. Then I'm asking, okay, Samuel, can you lie down? I'm going to check your tummy also. I'm checking his liver also. Is there any hepatomegaly?
No hepatomegaly.
Okay, then I am checking the pedal edema. Any pedal edema?
No pedal edema.
Okay. Thank you, Samuel. You can read now. So I'd like to complete my examination by checking all forelimb BP, saturation, and radiofemoral delay and radio radial delay. And I would like height, weight, the Tanner stage. Tanner. I would like to plot the height, weight in the age appropriate growth chart and Tanner staging.
Okay. You have still some more
20
time left.
seconds left, sir. Yeah.
How many?
20 seconds.
Okay. When it is finished, you tell us, then we'll move on to the
Okay.
questions.
Okay, sir. So today I got the opportunity to do the
Just a second.
detail.
You have 20 seconds left. So it has to be started after the bell rings, the summary.
Oh, okay, sir.
This is examination part.
Yeah, sir. Time's up.
Okay. Now you can summarize your positive findings.
So today I got the opportunity to take a detailed cardiovascular examination of Samuel, 10-year-old Samuel. He's on examination. He's having a clubbing with cyanosis, and there is a conjunctival congestion is there. With medial on the inspection, there is medial sternotomy scar and this lateral thoracotomy scar in the right side, and single on auscultation there is single heart sound and the apex in the left fifth intercostal space, and there is no murmur, uh, and his height weight below the average.
Okay.
So, then cyanotic congenital heart disease with the uh, post surgical, then no evidence of no failure, no clinical features of infective endocarditis.
Okay.
And
What kind of cyanotic congenital heart disease do you think it can be?
pardon, sir.
What kind of cyanotic congenital heart disease can it be with two scars?
Medial sternotomy scar with cyanosis is there, so I will think about complex cyanotic congenital heart disease
Okay.
with failure of still cyanosis is there, so failure of the procedure.
Okay. Okay. So how would you like to investigate this child?
Yeah, sir. So I would like to review all his previous records, and I would involve my consultant and cardiologist. So I'll send the investigations, including ECG, echo, and chest X-ray, and basic investigations like a hematocrit because polycythemia is there, and full blood count, ESR
Okay.
blood culture also. Yeah.
Okay. Okay. Suppose that his PCV is like 75.
Okay,
So
sir.
how would you like to manage this? He is not having any symptoms.
Yeah, sir. First of all, basic hydration is important, like IV hydration, and based on his vitals and conditions, if needed, after discussing with the consultant, PRBC
Okay.
transfusion.
Okay. What advice would you like to give to this child and the parents?
Yeah, so first of all, I would like to explain the nature of the disease with the family and educate the parents and importance of adequate hydration, avoid high altitude, and maintain dental hygiene, avoid piercing, and avoid strenuous exercises. And I would like to educate about the infective endocarditis prophylaxis and also
Okay. So what infective time is over? Oh no. What infective endocarditis prophylaxis would you like to give this child, if at all it is needed?
it is a cyanotic congenital heart disease, so definitely this infective endocarditis prophylaxis he
Time's up,
needs
sir.
Okay. Good. Fine.
certain pencil. Yeah,
Okay.
yeah, that's
So, what do you think, Dr. Reshma, can this condition be? Like it's complex cyanotic congenital heart disease. That's the right answer. That has to be put like that. There are multiple things without any obvious finding. But your second heart sound, you could make it out that it is single. So, what do you think can it be?
so this pulmonary the cytokine memorization, sir.
In
That
isol memorization, P2 will be very loud, right?
yeah, yes.
Yeah. So, in this P2 was not loud. It wasn't palpable.
Failure of the procedure, sir, with
Yeah.
right ventricular
Maybe
hypertrophy.
right thoracotomy was done. First right thoracotomy was done. So they might have done some shunts like BT shunt, right? Followed
Mhm.
by followed by another surgery in which like it is a complex cyanotic heart disease. So it can be a single ventricle physiology in which like BT shunt like it was done as an initial procedure and then the shunt gets blocked because he's very cyanosed, right? Then they had put like towards single ventricle physiology, maybe. Right.
Mhm.
Maybe they have
Yeah.
done a Glenn. And even Glenn is failing because he looks very cyanosed and he is now 10. His Fontaine completion should have been done earlier. So that way it can be failure of the procedure or he has outgrown the procedure. That can also be the answer. The procedure like BT shunts don't grow, right? The child grows, BT shunt doesn't grow. So the child has outgrown the shunt. It can be
Oh,
also thing. Okay. Not always failure. It can be like the child has outgrown the shunt procedure which was done. Okay.
oh,
So in your examination part, it was like good. You tried to examine all the parts in a systematic fashion. It was good that you saw the axilla for this child because he was 10. So signs of puberty, and you also mentioned in the right that in the last. So that was very good. And you had kept a time with yourself for the last part in which you want in which you summarize for the things which you want to do, but you can't do because of the lack of the time. Like in order to complete your examination, you would like to do like this. So that was important. So that was good,
Yeah.
I think. So this in these sort of cases, you have to come out with complex cyanotic congenital heart disease only. You can put that differential, and then the investigations for all the CVS cases are the same. You have to go through a chest X-ray, ECG, echo. That is standard. But in conditions which are so severely cyanotic, don't never forget about the PCV for these children. That is very important. Okay,
Okay, sir.
never forget about the PCV for this. And then you can please speak out. Don't put messages. It's better that everyone hears. Those who want to ask questions, try to speak out. That's okay. You can put in the last. That will be better because everyone can hear it. Okay, and so someone has asked, why can't it be a TOF? Can it be a TOF?
As sir, there was single heart sound, and
So, okay.
it cannot be like because in top there is S2 is soft actually.
Yeah, S2 is soft, and if it is very much stenotic, S2 can be like not even heard also, right? If it is very much severe,
Yeah,
or TOF can be with a pulmonary atresia variant also. TOF has a variant
yeah,
of pulmonary atresia, or if it is very severe, you will not hear the S2. Okay?
yeah.
Right.
And if the procedure has been done, so there may be some like if it is the PS has been opened,
Correct.
there can be some murmur as well,
Yeah,
or like
TOF
BP shunt
post-operative.
murmurs.
Correct. Initially, if it is was there, it can be a TOF, but post-operative with a sternotomy scar, very less likely that it can be TOF because he is very much cynosed. In TOF, they will close the VSD invariably and they will do the RVOT resection, right ventricular outflow tract obstruction resection they will do. If it is coming again, it will be very severe RVOTO, but to get cyanosis, you should have some right to left shunt. They have already closed the VSD. So less likely that he will be so severely cyanosed. There can be residual RVOTO, there can be again RVOTO can develop, but he cannot be so much cyanotic if it is a post-operative TOF. Okay, you can put TOF as a variant, but don't tell it in the upfront, right?
And
That's
sir,
why we
what
cannot
about
put.
JVP? Should she consider the JVP as well in the examination, just
Distended
to
neck
inspect?
veins, you have to comment. Distended neck veins, you can't comment on the JVP because it takes at least 30 seconds to 45 seconds to assess it properly, right? So if there are no distended neck veins, you can come out with it. You can say that there are no distended neck veins, but in order to complete your examination, you should consider JVP also. Speak out JVP. It's not recommended that you comment on the JVP while you are examining. If there are
Okay.
obvious
And what
distended
about
neck veins, you can tell.
doctor told regarding the position? Is it 45-degree? Did she mention it? Like the examination of cardiovascular?
Examination of the cardiovascular system for which part? Whole of the cardiovascular system, there is no
Done
recommendation to
on.
examine in 45. There is no
So it can be done
recommendation.
on.
Correct. It
Yeah.
can be done
Okay.
in the couch. For JVP,
Okay.
they
Okay.
recommend it to be at 45 degrees, not for whole of the CVS examination.
Okay.
Okay, na? Okay, good.
But inspection, during inspection, we have to inspect the child, the precordium from right side and from the foot and no, sir.
Yeah, yeah. From
Oh,
basically from the right side and the foot end, at least these two. Right. For
okay,
any
okay.
precordial bulge and all. That's important. You have to comment on this. Okay.
Sir, when there is a time that examiner says, present your case. So on
Okay.
that time, we should straightforward present our case, or we should first comment that in order to complete my examination, I would
Yeah,
like to check this. So we
I got your
when
point.
we supposed to say this
So I'll tell you,
first.
it's a very
Hmm.
good question. I'll tell you. See, for the initial 6 minutes, when you have entered into the examination room, you have 6 minutes plus 3 minutes. Okay. The 6 minutes are for you to examine the child, and
Hmm.
those parts which you could not examine due to lack of time, which is like known, which will be there.
Yes,
So in
yes,
those
yes.
6 minutes only, you have to tell that you have finished that thing. Then you say, okay, the child will be dressing. So in order to complete my examination, I will would like to do this. Okay, and that
Okay,
has to be finished within that 6 minutes because in the last 3 minutes is only for the viva, which will start with summary of your positive findings, then your
mm-hmm.
investigations and management. Those 3 minutes will be for that. In the initial 6 minutes, you have to examine, And those part which you cannot examine due to the lack of the time or you have forgotten, you can verbalize them in order to complete.
Okay.
Because if you encroach into the last 3 minutes, the timing for clinicals will be gone. Because for your physical examination, the part which you have done, you had 6 minutes. You will be marked maximum two, the way you are doing. But your C, D1 and D2, your 6 out of 8 marks are remaining in the last 3 minutes. So the
Okay.
identification of the clinical signs can only be like taken out from you when you are verbalizing, when you are taking the examiner. So in the summary, you have identified some clinical signs. So when you are summarizing, this part will be marked for you. Then the reasoning, the
Okay.
parts which you have got, like, okay, you got something like a pansystolic murmur. You are putting the DD as a VSD. So you are giving a correct reasoning for that. So then you will be given a marks for that, 2 marks. And management
Okay.
planning will be that due to that. So your 6 out of 8 is in the last 3 minutes. So don't
Mm-hmm.
encroach any part of that 3 minutes. Otherwise, you will have less time to answer these questions, which are of carrying 6 marks. So in order to
Yes.
complete your examination, wala part comes in the 6 minutes only, initial 6 minutes, not
Okay.
in the last
Okay.
3 minutes. Okay,
Yes.
be very
Mm.
sure of this. Okay, a good question. Any other
Sir,
doubts in this
it's
case?
like we are starting from the hand. So is that it's a cyanotic heart disease, like BP? Tell me about the BP. Is it important to take in this, or let's in cyanotic heart disease we can ignore? We can
BP
just
is always important in the case of a congenital heart disease or a CVS case. We cannot say that BP is not important, but you cannot do the BP at this stage because it takes time. You have just 6 minutes to do everything. So,
so we
in
will
order
just
to
say that
complete your
I will do
examination,
it.
yeah, in order to complete your examination, you will put BP also there. You have to tell that.
Okay.
You cannot do the BP there. Okay?
Okay. Thank you.
Okay. Management of high PVC. Who will tell this? Someone is asking, iPhone 11 is asking management of high PVC, PCV. So who will tell this? Fast. Any one of you can tell. Dr. Reshma had told you can finish it off. Dr. Reshma, yeah.
Yeah, sir. So first of all, we have to hemodynamically stabilize the child. We have to check the vitals. Then if assess the hydration status of the child, and then we can hydrate the child properly. If
Good.
the IV
That's very
hydration.
important. Correct. Okay.
Then
So what happens? Yeah. Carry on, carry on. Sorry.
yeah, then if needed, this transfusion after discussing with the consultant and cardiologist.
Yeah. So what is important is whenever PCV is high, you have to confirm it again. If it is symptomatic or asymptomatic, if it is symptomatic with a high PCV, there is no clear-cut cutoff for cyanotic congenital heart diseases in children who are above the neonatal age group. For neonates, we have specific cutoffs, right? You must have read in neonatology. So, okay, 75, above 75 without any symptoms, you have to do exchange transfusion or a phlebotomy. For cyanotic congenital heart diseases, for children or adults, there is no specific cutoff. But for practical purposes, anyone who is having polycythemia with symptoms, we hydrate them always and we do phlebotomy for them, right? For
Hydration
those
symptom.
who are asymptomatic but the PCV is very high, above 75 and all, then also we hydrate and do phlebotomy. If it is lesser PCV but and he is not symptomatic, like the PCV is somewhere around maybe 55 to 60 or 60 to 65, then we normally hydrate them well and ask them to keep good hydration. That's important. Okay, so phlebotomy is to be done when he is symptomatic in any case along with hydration or the PCV is very high. Okay, right? And how much blood is to be taken out? That formula also is for neonates only. The PCV which is there minus the desired PCV which we normally keep at 55 divided by the PCV, original PCV, into 100. So you can take the blood volume, that much is to be taken out. Remember that you will hydrate the patient with equal volume, the amount which you have taken out. Okay, that's
So,
important.
sir, how much desired PCV? 55%?
55 we keep. That is all the guidelines are for neonates. There is no specific guidelines for congenital
Okay,
heart
okay.
disease till date. So we
Okay,
keep
okay.
it as around 55 to 60. Okay,
Okay.
this is
So
all
that
center
is
based.
the 3 times of the hemoglobin, the
Sorry.
hematocrit. The hematocrit should be like 3 times of the hemoglobin.
Yeah. That is like rough idea. Correct.
One
You are
is to
right.
three. Yeah.
Correct. That is the general idea. So if your hemoglobin is 20, the hematocrit should be around 60. That is like to know the general idea. So, but in this case, it is recommended that you get the clear PCV, the value. You have to get the
Yeah.
values from the lab and then act. We do not act on
Yeah.
hemoglobin, we act on PCVs. Right? That's important.
Yeah. Better. Yeah.
Correct, correct.
Sir, I have a question. Like, if this scar would be like BT shunt scar would not be like that, that is shown in the as you shown.
Thoracotomy, lateral thoracotomy scars will be there. It won't be so long. It
Yeah.
can be of BT.
That
See,
is
BT shunt can be done by a sternotomy also.
okay.
BT shunt is mostly done through lateral thoracotomy, but it can be
Yes.
done through midline sternotomy scar also. So do not hesitate in telling, like if you are getting a continuous murmur of a BT shunt and all, and you think the child is cyanotic and there is continuous murmur, you can tell BT shunt. So if they ask you why is it not thoracotomy, BT shunt can be done via sternotomy. My surgeon does it preferably from sternotomy. So it is surgeon dependent, right? It's not that
Okay.
sternotomy say any surgery can be done. Thoracotomy say there are few surgeries which can be done, like coarctation repair, BT shunt, PA banding, okay, minimal
Okay.
invasive cardiac surgeries. Those can be done through thoracotomy or lobectomy. But sternotomy can do all of these. All the surgeries
Hmm.
can be done. So BT shunt is done
Okay.
by a sternotomy also. Okay, it's
Sir, where is the scars in case of Fountain and Glen, sir?
it will be midline sternotomy scar. So
Midline
for
only. Okay.
correct. So for what do you say? Uh, for lateral thoracotomy scars for cardiac surgeries, you will have your BT shunts, your coarctation of aorta repairs, your PA banding. Okay, PA
Okay,
banding
sir.
can be done, or minimal invasive cardiac surgeries are there in which lateral thoracotomy scars are there. Okay, for
Do
cardiac.
they have this like sub-mammary approach and all I saw in
Yeah,
case
they
I got
have
confused?
sub-mammary
Yes.
approach also.
Okay.
In mix, there can be different approaches. So it
Okay.
can be sub-mammary also, just to hide the scar.
Okay, sir. Okay.
Correct. Okay. So for practical purposes, if you have a sternotomy, everything is possible. It's not that BT shunt cannot be done via sternotomy, or a coarctation repair cannot be done via sternotomy, or a PA banding cannot be done via sternotomy. All of these can be done and are being done these days also, depending on the cases. Like if there is coarctation of aorta and the coarctation is for a longer segment, the arch is also hypoplastic, so needs to the surgeon needs to remove whole of the arch and make it bigger, so he cannot do via thoracotomy, right? He has to
Yes.
do a sternotomy. So all these surgeries which can be done via thoracotomy can 100% be done via sternotomy.
Okay,
Okay,
sir. Okay,
but
sir.
those surgeries which are specifically done via sternotomy, it is not necessary that they can be done via thoracotomy.
Got it. Yeah.
Correct. So why wasn't there any murmur in this case? Because BT shunt, which we think that the lateral sternotomy scar might have get blocked, the child has overgrown the shunt, and since Glen has been done, so and there was a single S2. So when they do the Glen, na, they will obstruct the forward flow from RV to PA. No blood flows normally, except in a few cases. So they will obstruct the forward flow and they will directly connect the SVC to pulmonary
Yes.
artery. Right,
Mm.
SVC to RPA, right pulmonary artery. So you won't get the second heart sound. Only single second heart sound is there due to A2 component. There is no P2 component. That is why you are not getting any second heart sound, single heart second heart sound. Correct? And no murmur.
Okay, sir.
But in active shunt, we might get a continuous type of murmur.
In which shunt?
If it is acting shunt of
Glen.
Fontaine or Glen
No, no, no. In Fontaine or Glen, you do not get any woe. If there is a
murmur.
like
Okay.
forward flow, you mean like RVOT, RV to PA blood is going.
Okay.
If they're correct, no, normally what they do when they are doing the Glen or the Fontana, the rule is they will obstruct the blood flow which is occurring from RV to pulmonary artery, right? They will tie it. So that murmur goes. There is no murmur in that case because the pulmonary artery, RPA, they connect the SVC to RPA. In Fontan, what they do? They connect the IVC to RPA. So both SVC and IVC are connected. So there is no murmur in these cases because the forward flow across the RV to PA is obstructed. So you do not get a murmur in the case of a
Yeah,
glen or a fontaine. If
Glen or
they do
Fontaine.
not obstruct, in some of the cases, in rare cases, they do not obstruct. After doing the glen, they do not obstruct the RV to PA. Then you can get a PS murmur if PS was there. If it is a case of
Okay,
like
okay.
TOF like physiology, something like that, then PS murmur can be like obtained.
So, sir, in only TOF, when there is shunting, there will be only continuous murmur. Otherwise, in all shunts, we will not get any murmur.
Sorry,
Like in
sorry,
Glen or Fontaine, you
sorry.
explain.
I didn't hear you. Sorry.
As it is in BT shunt, we find a continuous murmur, but in Glen and Fontaine, we will not find any continuous murmur.
Correct. You won't find any murmur. Correct. You're right.
Thank you.
100% right. Good. In Glen and Fontaine, you do not find any murmur due to these shunts. You're right. Good. So we'll move on to the third case.
I have a doubt, sir.
Yeah, sure.
Sir, uh, complex complex cyanotic heart disease or complex heart disease? Which term we are using, sir?
This is a complex heart disease. Since there was cyanotic, you can use the term cyanotic.
Okay, sir. So
Complex heart
means
disease can be anything. Even acyanotics can be complex, right? It's not that they
yeah,
cannot be complex. But since you saw cyanosis, clearly clubbing is there, cyanosis is there, even the oral cavity. So complex cyanotic congenital heart disease. Correct.
sir. When we are telling complex means medial sternotomy scar.
Mhm. Complex when you are not able to find out, like, see, if there is anything which is lying inside, can be anything. We also do not know, right? There can be something, there is cyanosis, we are not able. If there is top physiology, you can say that PS is there, you can hear the murmur, right? In this case, you are
Mm.
not hearing. There are multiple surgeries. So it cannot be something like very obvious, right? It can be a
Mm.
complex heart disease only, because in 6 minutes you cannot comment on like is it going into this pathology or physiology or not. You can clearly tell ki, okay, there is something complex cyanotic heart disease which is lying inside. Correct? You
Okay,
cannot comment on much on 6 minutes.
okay, sir. Acyanotic heart disease also can be complex, no, sir?
Complex means anything. There is no clear cut definition for complex cyanotic or acyanotic. Anything which is not like the clear routine. Acyanotics can be complex. Correct.
Okay.
Correct. Unbalanced AV canal defects, DORV, VSD physiology, multiple VSDs. These will be acyanotics and complex.
Okay, okay, sir.
Hmm. Okay. Okay, Dr. Reshma, you have generated a lot of good discussion. Someone is writing an extensive cardiology session by a cardiologist. Okay, we'll move on to the third thing. Video, Dr. Shajita. Dr. Shajita, I'm not sure if you have done this video sometime. If you have ever done this video recently, then you might give it to someone else. You
Okay,
can.
sir.
Have you done this video recently or?
Uh, it was done in one
Okay.
of my stations. Yes, sir.
Okay. If you want to do, we can do it. It wasn't if it wasn't done by you.
Yeah, it wasn't done by me.
Okay.
Yeah.
If you want to do, you can do, or you can give it whatever you wish.
Uh,
Okay.
so it's okay, sir. If anybody wants to attempt, they can. Or I'll.
Okay. You only do and finish it off.
Okay.
Okay. So for the video station, normally this is one of the stations in which we expect that all of you should get 6 out of 6 marks, because video stations are all like clear cut. They are all repeats. They have a question bank of videos and they'll be repeating from it only. So all the videos are like it's out, somewhere out. So you cannot get anything less than 6 out of 6 in both the video stations. Don't ever try to attempt to get anything less than that. And you have, like, for the identification of the clinical signs you have 2 marks, for the reasoning for those signs you have 2 marks, and for the management planning normally you will have 2 marks for it. And this video station, you have 3 minutes to see the video. Normally outside the video station you will be told what it is there, like one or two liners will be there, this is the video of a child, and there is audio or not, they will clearly tell you outside only. So 6 minutes for your discussion. This is a station in which you have lots of time to discuss. So your explanations and discussion should be elaborative. So I think maybe Dr. Reshma can put the timer for Dr. Shajita if you're okay.
Oh, okay, sir. I
Yes,
am
sir.
put 3 minutes.
Okay, there is no audio to this video and you can see this video. You have 3 minutes to see this.
Understand?
Right.
Yes.
Time is over.
Yeah.
Okay. So
Can
you
I?
can describe your findings, doctor.
Okay, I'm
Yes, sir.
putting the seat. Yeah.
Yeah.
Yeah, yeah. Okay. I was able to see a video in which there were two children and one attendant, probably their father, being examined by a doctor, and there was also a cameraman or yeah, somebody who was taking the video in the background, and one of the children, the child had. Some orthotic cast in his hand, and they were being examined, and both the father and the child had elicited signs of hypermobility in the joints like the hip and knee and the small joints of the hand as well. um, yes, sir. So
Okay.
uh, yeah,
So,
since there is two children and a father being examined, I would think of some genetic condition of hypermobility syndrome in
okay.
them. Yes, sir.
So what differential
Probably
would you like to put? Like what all conditions do you think can be there?
hypermobility could be there in Marfan syndrome, Ehlers-Danlos syndrome.
Mhm.
It could be a normal variant, and osteogenesis imperfecta also has
Okay.
hypermobility. Yes, sir.
Okay. What features of Marfan's could you see in these children or the father? What other features other than this
They,
hypermobility? Any other features, or you looked for these points?
they, I was not able to look at their eyes, but they were looking tall. Though I would like to plot them. Yes, sir.
Okay.
There was no dysmorphism. Um, I'm not sure, sir. Yeah.
Okay. So what points in history would you like not to miss in these children?
I would like to ask about the onset, since when they have been finding this, and if is there any pain in any of these joints, and if they at any point did they have any dislocation at any of these joints, and is there any vision problem, and is sorry, and is there any cardiac symptoms like any palpitations or tachycardia suggestive of underlying cardiac lesion, or if they're already diagnosed with a cardiac lesion? And I would also ask for any skin hyperextensibility, or if there is any easy bruising or any cigarette scar syndrome that could be suggestive of an Ehlers-Danlos, and if there is any fragile bones, past history of any fractures, family history of similar complaints, and consanguinity in them. Yes, sir.
Okay. So how would you like to examine them?
I would like to plot the dimensions of them, height, weight, and arm span. And then I would like to do a complete head to toe examination, including complete musculoskeletal examination, P-GALs, and a complete Baytons. And I would also do a visual optal examination for them, visual acuity, and then clinically cardiac examination to look for any mitral regurgitation, murmur, or I'd also look for signs of hyper, like an aortic regurgitation signs. I would look for, sir. Yes.
Okay.
And then
Mm-hmm. So suppose that it's a case of Ehlers-Danlos syndrome. So how would you
okay.
like to investigate these children?
If it was an Ehlers-Danlos, then I would like to first confirm my diagnosis by doing a genetic analysis for them,
Hmm.
and I would also do the other supportive investigations like a complete ophthalmic examination. I would do a CBC with peripheral smear, because with the bleeding time, because they are having easy bruising and platelet dysfunction also they have, and I would do a coagulation profile as well, a cardiac evaluation, and yeah, they are also more prone for mitral regurgitation and aortic root dilatations, and I would also do a cognitive assessment for them. Yes.
Okay.
Yeah.
So in the management of these children,
Mm, mm.
so what advice would you like to give to the parents and the child per se?
Advice, first of all, I would advise them, because they are able to extend their joints, not to do it repeatedly, or they will go for dislocations, and it will increase the pain. And I would also advise them to maintain an ideal weight, not to go into obesity, because if at all they have any scoliosis, it will worsen. And I would advise them to avoid high contact sports, and to better going for any low contact, low impact, like a swimming. And I would also advise them about the warning signs of the sudden aortic dissection, or failure symptoms. I would advise them. And I would also advise them to use some built up pens and orthotic devices to relieve the pain in their joints, if at all they have any. Yes, sir.
Okay. So suppose that it is a case of Marfan syndrome.
Okay.
So what other things like evaluation, which all teams would you involve for this?
I would like to involve my consultant, and cardiac evaluation for them, to do a echo, and complete ophthal evaluation to look for any dislocation of the lens, and orthotics to provide them any yeah, so this built up pens and any devices in the hands like this child was wearing. And then genetic counseling for the family, and a special education counselor to liaise with the school, and then psychological support for them as well.
Okay, what
Yes,
gene
sir.
is responsible for the case of Marfan's?
Marfan's, it is fibrillin gene, sir. Yes.
Correct. Okay, good. How much time is left?
Yeah, time finished, sir. Time finished.
Okay, okay.
Mm.
Because in video station, sometimes you might have like you might finish before time also, but it was good. So this is like something which was put it from like something odd, and they had tried to show the hyper extensibility in these children. So you should be prepared for any other video if they ask. Normally they will be asking from their question bank. Something out of the blue should also be like you should be ready in these cases. Okay, no? So someone is asking to repeat the video. I'll repeat the video once, and you can all can see this once. So he is showing his little finger, and there is something attached to it. We are not sure. We might not be sure also. Maybe it's for letting the joint subluxation not to be there. Some band-like thing is there. You might not be sure of that, so you can tell that. That's okay. In
Okay.
video, we cannot be able to tell everything, but at least you should observe and tell about it that there is something which is on the right wrist of the first child. See, he's showing that he's twisting his thumb very easily, showing that the joint is hypermobile, and he can easily do that with much ease. The second child is also trying to copy that. Okay, see the way he can take his legs above the head, like see the other child who is also trying to do mimic him the same, and he is able to do that. Now the father will start. He will show that. See the way it is like he can move extensively at the hip joint, also in the knee joint, which he showed. Right. So now the father is showing his. He is also able to do that, showing his thumb very easily. So at least you should be able to tell that this is some sort of like hyperextensibility and some connective tissue disorder. That's important. And then you can give a few differentials, which can be anything. So at least one or two you can give, and then they will keep on like the ball rolling for your Viva. That's important. Okay, I think this is now repeating itself. So you can have like the differentials, mostly like in these cases hyper extensible. You can put it like sometimes it can be like basically connective tissue disorder you have to tell, and Ehlers loss or Marfan's can be there. That's okay. These are the most common one which comes to our minds. So there are lots, but yeah, at least the common ones you should keep in your mind to say something. So family history is important in these cases because Marfan's is autosomal dominant, very important. Any history of like skin bruising, as it was like mentioned, that was important. Skin hyperextensibility, any joint pains, So weight was important here, like Dr. Shajita advised about keeping their weight in the normal range. That was important. And you should always inquire about the in children developmental milestones, coordinations. Those things are important. So for hyper extensibility assessment, so you have to do the full musculoskeletal system examination in these cases, do the skin examination in these cases, any forms, signs of like dysmorphism, see for the spine and all. Marfans can have like spinal deformities. How is the
Yes.
chest? How is the foot like?
Just deformities.
Correct.
Yes.
So those things are important when you are
Okay, sir.
examining. Okay.
Yes.
For investigation, the investigation of choice in these cases will be like genetic assessment, correct? Along with that, like ophthalmology, cardiological involvement. So for cardiology, like most important is like you should tell about aortic root dilatation rather than AR or
Okay,
MR.
sir.
Tell about
Okay,
the
sir.
root. Aortic root is the one which gets dilated.
Yes.
It can
Okay,
get
sir.
dilated even without like it might not lead to AR also. So,
Okay.
but aortic root dilatation is the most important thing. Even when we are
Mm.
not getting the murmur, na, you have to send to a cardiologist for assessment because aortic root dilatation might have started.
Okay,
So
sir.
that way. Even today, I
Okay.
saw a child who was like 9 years of age. He had like aortic root dilatation without AR, no cardiovascular features, but he was like FVN gene positive. So that will
Okay.
tell. So
Okay.
aortic root dilatation is to be assessed and measured, and Z scores are there for that, and we assess them
Okay.
frequently that way.
Okay.
For the
Okay, sir.
treatment and all, what you said, advice is important. You should not be doing these hyper extensible movements again and again. And physiotherapy for strengthening of the joints and all, those are important. Their occupational therapy for their day-to-day activities, pain management and all will be needed. Okay, and normally for these, like they will need like genetic counseling and regular follow-up for these complications. So those are
Okay.
important this way.
Okay.
So with regards to the video station, like all of you should try to like in all the stations, it's recommended that you try to score the full, but in video it is a must. Like you all should be able to get full marks in it, and it is one of the stations in which most of the students will score full marks. So try not to miss those videos because all videos are like repeats. You know what all will be asked. So try to rehearsal on that. And because in these you have 6 minutes to discuss, so keep on like speaking in videos. You have ample time. Even for the investigations, when you are giving, you give the explanation for them. So you are going to do the genetic assessment. What do you want to see in that? You want to do the CBC. What do you want to see in that? So those things should be done. In history and video, you have ample time to talk to the examiner. So give elaborative answers with reasons for all. In clinicals, be to the point specific because you have 3 minutes also and you will be getting 6 marks in those 3 minutes. So be specific. Don't try to say much on all in clinical especially. So you have less, and even in development, you don't have much time during the Viva. So, but in history and video, we have lots of time. Okay. So I had three cases for today. Anyone wants to ask anything, any comments, anything, we can take. Otherwise, we'll close it after this. Any comments, anything you want? No questions, no comments. Okay, then we'll close the session.
It was a very nice class, sir. Very informative. Thank you so much.
Thank you. Thank you all. All the best. Keep on practicing. The only key to success is keeping on practicing. Okay. Keep on practicing. All the best.
Thank you so much, sir. Thank you, sir.
Thank you.
Thank you.
Bye bye. Thank you.